If you're taking the NCLEX soon, you need to watch this. These are the exact questions that appeared on the 2024 NCLEX multiple times. And trust me, you don't want to miss them. Question number 1, fat embolism syndrome. This question keeps showing up on the NCLEX 8 times in the last 5 years. January 2019, April 2019, October 2019, March 2020, August 2021, December 2022, May 2023, and September 2024. Scenario: a 35-year-old client with a fractured femur suddenly develops severe chest pain, confusion, and difficulty breathing. You assess them and notice tachycardia, low oxygen saturation, and subconjunctival petechiae. What's your priority action? A. Administer prescribed anticoagulants to dissolve the emboli. Sounds reasonable, right? But here's the catch. This isn't a blood clot, it's a fat embolism. Anticoagulants won't help because fat globules, not clots, are causing the blockage. B. Elevate the affected extremity to reduce swelling. Nope. Actually, elevating the leg could make things worse by allowing more fat globules to enter circulation. C. Prepare the client for immediate surgery to stabilize the fracture. I get why you might pick this, but it's not quite right. Surgery might be needed eventually, but the immediate life-threatening issue is the embolism, not the fracture itself. D. Notify the physician immediately for further evaluation and intervention. Yes, this is the correct answer because early recognition and medical intervention are critical. The doctor will likely order oxygen therapy, IV fluids, and respiratory support. Let me give you a quick NCLEX tip. If a client with a long bone fracture suddenly develops chest pain, confusion, and low O2, always think fat embolism syndrome. Question number 2, myocardial infarction and nitroglycerin. This topic is tested often, appearing 6 times in the last 5 years. Scenario: a client with crushing chest pain and diaphoresis is in the ER. Nitroglycerin is ordered. Which vital sign must be checked before administration? A. Respiratory rate. Nope. While important, it doesn't determine whether nitroglycerin can be given. B. Heart rate. Not the priority. Though nitroglycerin can affect heart rate, it primarily affects blood pressure. C. Blood pressure. Yes. Nitroglycerin dilates blood vessels, which can cause a dangerous drop in blood pressure. If systolic BP is below 90, hold the dose and notify the provider. D. Oxygen saturation. Important, but not the priority. We give nitroglycerin to relieve cardiac workload, but low O2 alone wouldn't stop us from giving it. Quick pro tip. Always check blood pressure before giving nitroglycerin. Question number 3. Stroke recognition. FAST. The NCLEX loves stroke scenarios. This has appeared 10 times in the last 5 years. Scenario: a client suddenly can't move their right arm, has slurred speech and facial droop. What's the priority action? A. Perform a full neurological assessment and wait for symptom progression. No time for waiting. This client needs immediate action. B. Call a stroke alert and prepare for a CT scan. Yes, time is brain. The CT scan rules out bleeding before starting clot-busting drugs, TPA. C. Check the client's blood sugar. Not first. Yes, we check glucose, but stroke must be ruled out ASAP. D. Elevate the head of the bed to 90 degrees. Not helpful. A moderate elevation is good, but this does not diagnose or treat a stroke. Pro tip: think fast. Facial droop, arm weakness, speech difficulty, so time to call a stroke alert. Question number 4. Diabetic ketoacidosis, DKA, and insulin therapy. DKA is a must-know critical care topic, appearing 8 times in the last 5 years. Scenario: a client with type 1 diabetes presents with cusmal respirations, fruity breath, and blood glucose of 580 milligrams per deciliter. Which intervention is the priority? A. Administer IV regular insulin. Yes, DKA is caused by severe insulin deficiency. B. Give 4 dextrose. Nope. Dextrose is only given when glucose drops below 250 milligrams per deciliter. C. Restrict fluids. Wrong. DKA clients need aggressive fluid replacement. D. Monitor urine ketones before giving insulin. Not the priority. Insulin must be started immediately. Let me make this clear. DKA equals dehydration plus ketones plus acid-base imbalance. Treatment is IV insulin, IV fluids, and electrolyte monitoring. Question number 5. Pulmonary embolism and sudden dyspnea. A highly tested emergency topic appearing 9 times in the last 5 years. Scenario: a post-op client suddenly develops dyspnea, tachycardia, and pleuritic chest pain. What's the priority intervention? A. Perform a chest X-ray to confirm diagnosis. Too slow. We suspect PE based on symptoms, so treatment shouldn't be delayed. B. Have the client ambulate to improve circulation. No way. Movement could dislodge more clots. C. Administer oxygen and prepare for anticoagulation therapy. Yes. Oxygen supports breathing, and anticoagulants like heparin prevent further clotting. Never delay treatment. D. Place the client in the Trendelenburg position. Incorrect. Trendelenburg is not used for PE. It can worsen breathing difficulty. Let me remind you, if a post-op client suddenly develops dyspnea plus tachycardia, think PE, oxygen plus anticoagulants, ASAP. Question number 6. Sepsis and early recognition. Sepsis is a high-priority emergency and has shown up at least 7 times in the last 5 years. Scenario: a client presents with fever, tachycardia, low blood pressure, and confusion. Blood cultures are pending. What's your priority intervention? A. Give acetaminophen for fever. Nope. While fever control is important, this doesn't treat sepsis. B. Administer IV fluids immediately. Yes. The biggest danger in sepsis is hypovolemia and shock due to widespread vasodilation and fluid shifts. Fluids first, then antibiotics. C. Draw blood cultures before giving antibiotics. Tricky. Yes, cultures are necessary, but fluids are the first priority to prevent organ failure. D. Give norepinephrine to raise blood pressure. Not yet. Vasopressors like norepinephrine come after fluids fail to stabilize BP. Tip: sepsis equals fluids. First, then antibiotics. Question number 7. Hyperkalemia and EKG changes. Electrolyte imbalances are frequently tested on the NCLEX. Hyperkalemia has appeared at least 9 times in the last 5 years. Scenario: a client with chronic kidney disease has a potassium level of 6.8 milliequivalents per litre and an EKG showing peaked T waves. What's the priority intervention? A. Administer sodium polystyrene sulfonate, Kayexalate. Not fast enough? Kayexalate works over hours, and this patient needs immediate treatment. B. Give 4 units of insulin with dextrose. Good, but not first. This shifts potassium into cells, but doesn't prevent cardiac effects. C. Administer calcium gluconate. Yes, calcium stabilizes the cardiac membrane and prevents life-threatening arrhythmias right away. Doctor, start hemodialysis immediately. Not the first step. Dialysis is for severe or resistant cases, but we treat acutely first with calcium, insulin, and fluids. Quick tip: peaked T waves plus high K. Give calcium gluconate first. Question number 8. Heart failure and furosemide. The NCLEX loves heart failure management. This question has been tested at least 8 times in the last 5 years. Scenario: a client with congestive heart failure, CHF, is short of breath and has 3+ pitting edema. The provider orders 4 furosemide. What should the nurse monitor closely? A. Sodium levels. Not the biggest concern. Furosemide can lower sodium, but something else is more dangerous. B. Blood pressure. Important, but not the highest priority. C. Potassium levels. Yes, furosemide is a loop diuretic that wastes potassium, leading to hyperkalemia, which can cause dangerous arrhythmias. D. Blood glucose levels. Not the priority. Though furosemide can raise glucose in diabetics, it's not the immediate concern. Reminder: always check potassium after giving furosemide. Question number 9. SIADH and hyponatremia. This endocrine condition is a popular NCLEX topic, appearing 7 times in the last 5 years. Scenario: a client with SIADH, syndrome of inappropriate antidiuretic hormone, has a serum sodium of 120 milliequivalents per litre and is confused. What's the best intervention? A. Give 3% hypertonic saline IV. Yes, severe hyponatremia less than 120 milliequivalents per litre can cause seizures and needs slow correction with hypertonic saline. B. Increase oral fluids. No, SIADH causes fluid overload, so we restrict fluids. C. Administer diuretics. Maybe later. First, correct sodium imbalance. D. Encourage a high sodium diet. Doesn't correct the root problem. NCLEX tip: SIADH equals low sodium, fluid restriction, and if severe hypertonic saline. Question number 10. Pulmonary embolism and sudden dyspnea. A highly tested emergency topic, appearing 9 times in the last 5 years. Scenario: a post-op client suddenly develops dyspnea, tachycardia, and pleuritic chest pain. What's the priority intervention? A. Perform a chest X-ray to confirm diagnosis. Too slow. We suspect PE based on symptoms, so treatment shouldn't be delayed. B. Have the client ambulate to improve circulation. No way. Movement could dislodge more clots. C. Administer oxygen and prepare for anticoagulation therapy. Yes. Oxygen supports breathing, and anticoagulants like heparin prevent further clotting. Never delay treatment. D. Place the client in the Trendelenburg position. Incorrect. Trendelenburg is not used for PE. It can worsen breathing difficulty. Let me remind you, if a post-op client suddenly develops dyspnea plus tachycardia, think PE. Oxygen plus anticoagulants, ASAP. Question number 11. Respiratory acidosis versus respiratory alkalosis. Acid-base imbalances are a common NCLEX topic and have appeared at least 8 times in the last 5 years. Scenario: a post-op client is found drowsy with shallow respirations and an ABG result of pH 7.28, PaCO2 56, HCO3 25. What condition is this? A. Metabolic acidosis. Nope, the bicarbonate HCO3 is normal, so this isn't metabolic in origin. B. Respiratory acidosis? Yes, low pH plus high CO2 equals respiratory acidosis. This client is likely experiencing hypoventilation due to opioid sedation. C. Metabolic alkalosis. No way, the pH is low, acidic, not high. D. Respiratory alkalosis. No. Respiratory alkalosis would have low CO2 due to hyperventilation. Quick NCLEX tip: respiratory acidosis equals hypoventilation, CO2 retention. Respiratory alkalosis equals hyperventilation, CO2 loss. Question number 12. Hypovolemic shock. Shock management is highly tested on the NCLEX and has appeared 9 times in the last 5 years. Scenario: a client with severe bleeding after a motor vehicle accident is cold, clammy, and has a blood pressure of 78/40 millimeters of mercury. What is the priority intervention? A. Administer IV fluids rapidly. Yes. Hypovolemic shock is caused by severe fluid loss, so IV fluids, normal saline or lactated ringers, are the first treatment. B. Place the client in high Fowler's position. No. This would decrease venous return, worsening hypertension. C. Administer norepinephrine immediately. Not yet. Vasopressors, like norepinephrine, are given only after fluids fail to restore BP. D. Obtain a full set of vitals and wait for provider orders. Too slow, immediate fluid resuscitation is needed. Tip: hypovolemic shock equals fluids first, then vasopressors if needed. Question number 13. Digoxin toxicity. Medication safety is a big NCLEX focus, and questions about digoxin toxicity have appeared 6 times in the last 5 years. Scenario: a client taking digoxin reports nausea, vomiting, and seeing yellow halos around lights. What is the priority nursing action? A. Encourage fluid intake to flush out the medication. Nope. Digoxin toxicity isn't treated with hydration alone. B. Check the client's potassium level. Yes. Hypokalemia increases digoxin toxicity risk, so we need to check potassium levels immediately. C. Administer the next scheduled digoxin dose. No way. If toxicity is suspected, hold the dose. D. Increase dietary fiber to reduce symptoms. Incorrect. Fiber doesn't affect digoxin levels. Tip: digoxin toxicity equals gastrointestinal symptoms, vision changes, bradycardia. Always check potassium. Question number 14. Post-op complications. Paralytic ileus. Post-op complications are always tested on the NCLEX. This question has been included 7 times in the last 5 years. Scenario: a client post-abdominal surgery has absent bowel sounds, a firm abdomen, and nausea. What is the priority intervention? A. Encourage ambulation. Nope. While movement helps, it's not the priority if an ileus has already developed. B. Offer clear liquids to stimulate bowel function. No way! The bowel isn't functioning, so food or fluids could cause vomiting and aspiration. C. Keep the client NPO and insert a nasogastric NG tube. Yes. A paralytic ileus means the gut isn't moving, so the best intervention is bowel rest and NG decompression. D. Administer a laxative. Bad idea. If there's a blockage, a laxative could worsen symptoms. NCLEX tip: post-op ileus equals no bowel sounds. NPO status, NG tube placement. Question number 15. Heparin-induced thrombocytopenia, shit. Blood clotting disorders have appeared 6 times in the last 5 years. Scenario: a client receiving heparin therapy suddenly develops a platelet count of 50,000 and new clot formation. What is the best nursing intervention? A. Continue heparin and monitor the platelets. No, this is likely HIT, heparin-induced thrombocytopenia, a severe reaction to heparin. B. Administer warfarin instead of heparin. Not yet. Warfarin is not used in acute HIT because it can cause further clotting. C. Stop heparin immediately and notify the provider. Yes. HIT equals stop heparin ASAP and switch to a different anticoagulant, argatroban or fondaparinux. D. Give platelet transfusions to restore levels. Nope, platelets are not transfused unless bleeding is present. Reminder, if platelet count drops in a heparin patient, suspect HIT and stop the drug. Question number 16. Hypocalcemia and Trousseau's sign. Hypocalcemia is a frequent NCLEX topic, appearing 6 times in recent exams. Scenario: a client recovering from thyroid surgery reports muscle cramps and tingling around the mouth. The nurse inflates a blood pressure cuff and the client's hand spasms involuntarily. What is the most likely cause? A. Hyperkalemia. Nope. Hyperkalemia causes muscle weakness, not this type of spasm. B. Hypocalcemia. Yes, this is Trousseau's sign, a classic symptom of low calcium. Thyroid surgery can accidentally damage the parathyroid glands, leading to hypercalcemia. C. Hyponatremia. Wrong. High sodium does not cause neuromuscular spasms like this. D. Hypoglycemia. Unrelated. Low blood sugar causes confusion, sweating, and weakness, but not muscle spasms. Tip: if platelet count drops in a heparin patient, suspect, hit, and stop Trousseau's sign, hand spasm with BP cuff equals hypocalcemia, the drug. Question number 17. Beta blockers and heart rate monitoring. Questions about beta blocker safety have been tested 7 times on the NCLEX. Scenario: a nurse is about to administer metoprolol, low pressure, to a client with hypertension. Which vital sign should be checked before administration? A. Heart rate. Yes, beta blockers slow the heart rate. If HR is below 50 to 60 beats per minute, hold the dose and notify the provider. B. Blood glucose. Important for diabetics, but not the priority. C. Respiratory rate. Not the main concern. Beta blockers affect the heart, not breathing. D. Potassium level, not necessary before giving metoprolol. Reminder, always check heart rate before giving a beta blocker. Question number 18. Hypernatremia and fluid management. This electrolyte disorder has been tested 5 times on recent NCLEX exams. Scenario: a client with dehydration and serum sodium of 155 milliequivalents per litre is confused and restless. What is the best intervention? A. Administer IV 0.45% normal saline, hypertonic fluids. Yes, high sodium means too little water in the blood. We need hypertonic fluids to hydrate the cells. B. Restrict oral fluids. No way! This patient needs more fluids, not less. C. Give furosemide, Lasix, to remove excess sodium. Nope. The problem isn't sodium overload, it's fluid loss. D. Administer sodium bicarbonate. Unnecessary. This is not a pH issue. Tip: hyponatremia equals too much sodium, too little water. Treat with fluids. Question number 19. Anaphylaxis and epinephrine administration. Anaphylaxis is a critical NCLEX topic, appearing 8 times in the last few exams. Scenario: a client receiving IV antibiotics suddenly develops hives, wheezing, and hypertension. What is the priority action? A. Administer IM epinephrine. Yes, epinephrine is the first-line treatment for anaphylaxis. It opens airways and raises blood pressure. B. Give 4-diphenhydramine, Benadryl. Not first. Antihistamines help, but they don't work fast enough in severe anaphylaxis. C. Stop the antibiotic infusion. Important, but not the priority. We do stop the infusion, but we must treat the airway and BP first. D. Apply oxygen via nasal cannula. Not enough. Epinephrine is the life-saving treatment. NCLEX. Tip: for anaphylaxis, give epinephrine first. Question number 20. NSAIDs and kidney function. This pharmacology topic has been tested 6 times in recent NCLEX exams. Scenario: a client with chronic kidney disease, CKD, is requesting ibuprofen for pain. What is the best nursing response? A. I will bring you some ibuprofen. No, NSAIDs are nephrotoxic and worsen kidney function. B. Ibuprofen is not safe for your kidneys. Let's ask about another option. Yes, NSAIDs reduce kidney blood flow, which can cause renal failure in CKD patients. C. You can take ibuprofen, but only in small doses. Still unsafe. Even small doses can cause kidney damage. D. Try drinking more water with the ibuprofen. Doesn't prevent the damage. NCLEX. Tip. NSAIDs, ibuprofen, naproxen are dangerous for kidney patients. Question number 21. Status epilepticus and medication administration. Seizure management has been tested 5 times on the NCLEX. Scenario. A client with epilepsy is having a continuous seizure lasting over 5 minutes. What is the priority action? A. Restrain the client to prevent injury. Never. Restraining can increase injury risk. B. Administer IV lorazepam, Ativan. Yes. Benzodiazepines stop seizures quickly. This is the first-line emergency treatment. C. Place a tongue blade in the mouth. Nope. Tongue blades can break teeth or block the airway. D. Apply oxygen and wait for the seizure to stop. 2. Passive. The seizure must be stopped immediately with meds. NCLEX reminder. Status epilepticus equals give lorazepam ASAP. Question number 22. Post-op wound dehiscence. This complication has been tested 7 times recently. Scenario. A post-op client reports sudden pain and the surgical incision is open with organs visible. What's the priority action? A. Reassure the client and cover with a dry gauze. Wrong. A dry dressing will dry out the organs. B. Cover the wound with sterile saline-soaked gauze. Yes. Keep the wound moist and prevent infection. Then call for help. C. Push the organs back inside and apply pressure. Never. This could cause further damage. D. Place the client in high Fowler's position. No. Low. Fowler's 15 to 20 degrees reduces tension on the wound. NCLEX. Tip. Wound dehiscence equals keep moist, call for help. Question number 23. Acute pancreatitis and pain management. This has been tested 7 times on the NCLEX. Scenario. A client with acute pancreatitis is experiencing severe epigastric pain that radiates to the back. The client rates their pain as 9 out of 10. What is the priority intervention? A. Place the client in a supine position for comfort. Nope. Lying flat can worsen pancreatic pain. B. Administer acetaminophen as prescribed. Not strong enough. Acetaminophen won't help severe pancreatitis pain. C. Give 4 morphine as prescribed. Yes, let me explain. Pancreatitis causes severe inflammation and opioids, morphine, hydromorphone, are needed to control pain. D. Encourage the client to drink fluids to stay hydrated. Wrong move. In acute pancreatitis, we keep the client NPO to rest the pancreas. NCLEX. Tip. Acute pancreatitis equals IV opioids plus NPO plus IV fluids. Question number 24. End-stage kidney disease and diet restrictions. NCLEX frequently tests kidney failure, appearing 6 times in recent exams. Scenario. A client with end-stage kidney disease ESKD asks about dietary changes. Which statement by the client indicates a need for further teaching? A. I should limit foods high in potassium. Correct. Too much potassium can cause dangerous arrhythmias. B. I will drink plenty of water to keep my kidneys working. Wait, let's pause. Clients with ESKD need to restrict fluids to prevent overload and hypertension. C. I need to eat a low sodium diet. Yes. Sodium control prevents fluid retention. D. I should eat more protein to keep my strength up. Not quite. In kidney failure, too much protein worsens kidney strain. Reminder, ESKD equals low sodium, low potassium, fluid restriction, and moderate protein intake. Question number 25. Increased ICP and positioning. This has been tested 8 times in recent exams. Scenario, A client with a traumatic brain injury, TBI, has a Glasgow Coma Scale score of 8 and signs of increased intracranial pressure, ICP. What is the best position for this client? A. Supine with the head flat. Nope. This worsens ICP by reducing venous drainage. B. Head of the bed at 30 degrees. Yes. Let me explain. Raising the hobby to 30 degrees promotes venous return and reduces ICP. C. High Fowler's position, 90 degrees. Too high. This can actually decrease brain perfusion. D. Trendelenburg position. No way. This increases brain swelling and worsens ICP. NCLEX. Tip. For increased ICP, keep the head midline and elevate HOB to 30 degrees. Question number 26. DVT prevention after surgery. This has been tested 5 times in recent exams. Scenario. A post-op client asks how to prevent deep vein thrombosis, DVT. What is the best nursing response? A. Crossing your legs in bed can help improve circulation. No. Crossing legs reduces blood flow and increases clot risk. B. You should wear compression stockings and do leg exercises. Yes. Compression stockings promote circulation and leg exercises reduce clot formation. C. Stay in bed as much as possible to allow healing. Nope. Early ambulation is key to DVT prevention. D. Take aspirin to prevent clotting. Not standard practice. Heparin or enoxaparin is preferred for clot prevention. NCLEX tip. DVT prevention equals early ambulation plus compression stockings plus hydration. Question number 27. Cirrhosis and ammonia levels. This has been tested 6 times on the NCLEX. Scenario. A client with cirrhosis has confusion, asterixis, flapping tremor, and high ammonia levels. What medication should the nurse anticipate? A. Furosemide, Lasix. Nope. Furosemide removes fluid, not ammonia. B. Spironolactone, aldactone. Not the priority. Spironolactone treats ascites but doesn't lower ammonia. C. Lactulose. Yes. Let me explain. Lactulose binds to ammonia and removes it via stool. It's the first-line treatment for hepatic encephalopathy. D. Omeprazole, Prilosec. Not helpful. Omeprazole is for stomach acid, not ammonia. NCLEX tip. Lactulose equals lowers ammonia in cirrhosis. Look for confusion plus flapping hands. Question number 28. Preeclampsia and magnesium sulfate. This has been tested 7 times in recent exams. Scenario. A pregnant client with preeclampsia is receiving IV magnesium sulfate to prevent seizures. What is the priority assessment? A. Deep tendon reflexes. D. TRS. Yes. Let me explain. Magnesium toxicity causes decreased reflexes, respiratory depression, and cardiac arrest. B. Blood glucose. Not a concern here. C. White blood cell count. Doesn't relate to magnesium toxicity. D. Fundal height measurement. Not relevant to preeclampsia. Tip. Magnesium toxicity equals low reflexes, low breathing, low urine output. Watch for it. Question number 29. Chest tube disconnection. This has been tested 6 times on the NCLEX. Scenario. A client's chest tube accidentally disconnects from the drainage system. What is the best immediate action? A. Clamp the chest tube. No. Clamping can cause tension, pneumothorax. B. Submerge the chest tube in sterile water. Yes. This prevents air from entering the chest. C. Call the provider immediately. Important, but not first. Fix the problem first, then notify the provider. D. Remove the tube completely and apply a dressing. Never remove a chest tube without provider orders. Tip. If a chest tube disconnects, put it in sterile water to prevent air entry. Question number 30. Organ donation after brain death. This has been tested 5 times on the NCLEX. A client is declared brain dead and the family is unsure about organ donation. What is the best nursing response? A. I will have the provider explain your legal options. Not quite. The nurse should initiate the conversation. B. We must respect the client's prior wishes. The family still needs to be informed and involved. C. Would you like to speak with the organ donation coordinator? Yes. Let me explain. It's the nurse's job to facilitate this discussion and refer the family to the right resources. D. Organ donation is required after brain death. Wrong. Donation is never mandatory. Tip. If a family is unsure, offer to connect them with the organ donation team. Boom! You just tackled some of the most frequently asked NCLEX questions of 2024. But don't stop here. The NCLEX is testing these types of questions over and over again, and I've got even more coming your way. So, if you want to make sure you pass on the first try, hit that like and subscribe button and turn on notifications. We drop new high-yield NCLEX questions every week, straight from the 2024 exam trends.